there's been so much advances, right? And we have all these great trials, but I think trying to make sure we can keep patients on the agents that we're prescribing is really critical. So I think, Alan, you alluded to this earlier that, nivo-ipi may not be for everyone because different things. So how do you sort of optimize, how do you maintain dose intensity, density in these trials? Like what are some different things you think about in the clinic to, if you choose nivo-ipi, keep it going, or nivo-cabo, or pembro? How do you think?
Yeah, I mean, with ipi-nivo, it's all about trying to get up to that 4 doses of that induction period, right? And cross your fingers that they don't have that grade 3, grade 4 event, which, if they do, it's manageable. And oftentimes, if they do have that grade 3, grade 4 event, it's oftentimes associated with efficacy. So eventually they'll get that 3-month scan, and then if they're responding, I think once they get back on the single agent nivolumab, the turbulence is hopefully disappeared, and they can maintain on single agent our PD-1. As far as the IO-TKI, I think I use a lot of cabo-nivo. I think the fact that they start with the 40 milligrams instead of the 60 milligrams is key there, because these patients oftentimes are able to tolerate it better than some of the other ones. And with all of the TKIs, it's going to be cumulative. So I tell these patients, even though you're tolerating it now, maybe 8 weeks from now, 12 weeks from now, you're going to hit a threshold. And so depending on the patient, some of my patients have been on for so long, they know their personal threshold. And there's been studies about intermittent TKI. Some people have taken breaks as long as 90 days, and it really hasn't impacted survival. There's the STAR trial and then the TIDE-A study that was presented at ESMO that's showing that in some patients that might be feasible. But overall, I tell patients, if you have to take some breaks, to wash out that toxicity back to grade 0, grade 1, by all means, or if you have a wedding coming up and you want to be at your best, your daughter's wedding, I'm okay with that.
I do think that, and I don't have any, prospective data about this, but I'm someone who really believes that comprehensive counseling of the patient to reassure them that communication is not going to undermine our enthusiasm for treating their cancer. So I certainly spend a lot of time talking to folks about the idea that number one, it's not their job to know if some symptom they have, if it's bothering them. It's not their job to know if it's from their treatment. That's my job. So I tell them, let us know and I will determine. You don't, because I think people get kind of analysis paralysis, thinking, was that my taco or is that my medicine? I'm not sure. But I think just encouraging them, and I tell patients, if you have an unpleasant symptom that lasts more than 1 day, I need a call on day number 2, and I will help you figure it out, because that gives us the opportunity to intervene earlier and hopefully allow us to re-challenge patients. I think that helps. And also reassuring patients that even if we have to, stop the ipilimumab component early, that they can still derive significant clinical benefit. I think trying to just reassure them that we're not going to take away all their treatment. We're not going to abandon them just because they have side effects. And the earlier we know, the more we can help them. I think that has been the single most important intervention in my clinic practice.
I think setting expectations is key. And I think the other thing too is, the way that we came about the doses in the context of these studies, is really how we dose chemotherapy.
Yes.
The FDA has a huge initiative for dose optimization, and I don't necessarily think that continuing to escalate, hitting the MTD and going one step below is really the right strategy for targeted therapy. As we've come to see, there's been some studies that have been done with cabo looking at different doses of cabo, and that actually efficacy is retained from a PFS standpoint, even at different dose intensities. So I think we do have some work to do in that regard, but I think patient education, holidays, treatment breaks are all ways to actually maximize their time on treatment.
Yeah. I think if you look at all the studies, they picked a starting dose, and that's what the studies did, and so I tend to follow that starting dose. But if you look at the same studies, over half the patients in every single IO-TKI study had to dose reduce, right? So I think it's really important early on, you said setting the expectation to the get-go, like, hey, most patients dose reduce, it didn't compromise efficacy. If you can tolerate the higher dose, you should take it. But if you can't, we shouldn't, because I want to keep you on this long term. We don't want to get into trouble by having you take something too long early on, because that may jeopardize our long-term care.
I agree. Absolutely.